Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice, that is, Hatvet's YouTube channel. We are thankful to our honorable speaker and session moderators for sharing their valuable time and knowledge with us.
Dear participant, welcome you all. And today speaker, Dr. Suriya K, is our old student of our institute. And, his father spoke to us yesterday. And as of now, he is doing, surgery in Chinese, Massey University, and previously he has finished his PAVE program, the same university at New Zealand, and some amount of program veterinary has worked as a trainee, in United States for a couple of months, and before that he was with us. So I welcome Surya to present, limb injuries in dog and its management. And our another moderator expert is Dr. Sivasankar, a renowned surgeon, and underwent his MS program in US. And he's also having a big group of Navally study student group. And he's also with us to give expertise in this area. I welcome both of them. Now I request Surya to present his topic.
Sir, is it visible?
Yes, sir, visible.
Okay, hi. Good evening, everyone. My name is Suriya K. I'm currently doing a small animal surgical internship here at Massey University in New Zealand. And I was just going to present an update at the request of Dr. Chandrasekar on distal limb injuries in canines. So the reason I chose to present on this topic and what I'll be talking about is mainly how we deal with things here at Massey University. We have what's called a working dog center here at Massey University at the veterinary teaching hospital. And that's mainly due to the fact that we deal with a great deal of working dogs almost on a weekly basis, if not a day-to-day basis. Military dogs, police dogs, Massey University being the only teaching hospital here in New Zealand. We are one of the go-to facilities for the military and the police and their working dogs. But in addition to that, due to the racing of greyhounds, which present with injuries to the distal limb, present to us, and then also livestock. So New Zealand is a farming country, the main industry being dairy farming. Oh, sorry. Yeah, I'll try to speak a bit slowly. Sorry. Habits of me coming from America. So we mainly have a lot of farming dogs. Mainly it's due to dairy farming being the primary industry in New Zealand. After that, it's sheep farming. And so to rear and herd these animals, if you go to these farms in New Zealand, what you'll see is there'll be acres and acres and acres of farmland. And the cattle herds often run in 300. That's the average number of cows. Sheep herds run in far excess of that. And so it's very difficult for one farmer to manage these herds numbers. So they'll often employ dogs that have specifically been bred and then trained to manage their livestock. In Chennai, when I was there in Chennai, and in the US as well, but we see more long bone injuries, so fractures of the humerus, fractures of the radius, fractures to the femur, to the tibia. I think this is mainly due to the fact of the urban population and then the road traffic accidents that occur in these city centers. Here in New Zealand, we have these working dogs which are doing high performance daily activities. And New Zealand is a mountainous island. So they're performing these activities. If you look at these farms, they'll always be in very rugged terrain. So their daily activities are performed in uneven surfaces, which places a large amount of physical stress on the supporting structures of the distal limb, primarily the tarsus and the carpus. And just continuing. So, for example, this week we had a dog that presented, a police dog, and this dog lives a much more active lifestyle than most humans I know. It was actually not a distal limb injury case; it was a necrotizing fasciitis case. But when talking to the police officer who handles this dog, he said this dog had recently just climbed on top of some roofs and then run over train tracks. And if you think about this, and you think about a dog that is running with a lot of intensity, so it's suddenly stopping and starting. That's a lot of stress and strain being loaded onto these joints. There's a lot of movement in a sagittal plane from side to side, and a lot of sudden stopping. So even more slowly, I'm sorry. There's a lot of sudden intense change in direction in these dogs. And so this can often stress the kind of supporting structures, including the ligaments and tendons, as well as the bones that are present in these joints. Here on the left-hand side, this is kind of what you would see in most farming situations here in New Zealand. So you have a large sheep flock, and then what you'd have is primarily dog breeds, which are native to New Zealand, which are called heading dogs, and then huntaways. These are dog breeds that have been brought over from Europe and then kind of jointly bred into this mongrel breed, which is now native to New Zealand. And so what these dogs will do, these dogs cost upwards of 10,000 New Zealand dollars. So farmers are heavily invested in raising these dogs, the welfare of these dogs. Oftentimes, these dogs are insured. And so, what they'll do is they'll go, and some dogs will come around, some dogs will come from behind. One dog will, usually these dogs are very quiet, and only one dog will be trained to bark. And what they'll do is, through a process, they'll herd these sheep. So, these sheep will go, they'll go out to different pastures, they'll graze, and then the dogs are the ones which are tasked with going out and bringing these sheep back into their little paddocks to be protected overnight. And the same thing goes for beef cattle, the same thing goes for dairy cattle. Another popular that presents is greyhound racing. So greyhound racing is now being banned in New Zealand. It's going to get phased out over, I believe, an 18-month period, if I'm not mistaken. And while that happens to be the case, they present overwhelmingly to Massey University, and they always run in a counterclockwise fashion. And so, due to that, and due to the way that running at a high speed in a circle, loads the joints, they'll always present with injuries to the right limbs, either the right forelimb or the right hind limb. So I thought I'll just go over some basic anatomy before going into this. So here with the carpus, just going with what would be our first year anatomy in India. So the carpal bones are split into two rows. There's the proximal row and the distal row. So the proximal row, we're mainly dealing with three bones. So we have the radial carpal bone, which sits on the medial aspect, and then we have the ulnar carpal bone, which sits on the lateral aspect. And then on the kind of palmar lateral aspect, so basically on the back of the carpal joint, we have the accessory carpal bone. And then, going back to the second row, which we would call the distal row, we have the first to fourth carpal bones, and they increase in size going from medially to laterally. And then obviously they communicate with the metacarpals. And so this in totality forms the carpal joint, and we divide them into three joints when we're talking about the carpal joint in particular. There's the antebrachial carpal joint. So this is the antebrachium, right? And so the junction of the antebrachium and the carpus forms the antebrachiocarpal joint. Then we have the middle carpal joint, which is the communication between the proximal row of carpals and the distal row of carpals. And then we have the carpometacarpal joint. The primary range of motion of the carpal joint is going to be flexion and extension in a cradiocaudal direction. There's not going to be too much lateral movement in a medial and lateral direction. And the greatest amount of movement that actually happens in these joints mainly occurs at the antebrachiocarpal joint and as well as the midcarpal joint. The carpometacarpal joint isn't a very high flexion joint. So the ligaments of the carpus, so not to jump ahead too much, but if you think about the ligaments of the tarsus, you cannot necessarily compare them in one-to-one to the ligaments of the carpus. So if we think about our collateral ligaments, we have no long collateral ligaments across the carpal joints. So the medial and lateral support system is provided by short radial and ulnar collateral ligaments. So we have the short radial ligament coming from the malleolus here, attaching down onto the what's this? The central radial bone. And then we have the short ulnar collateral ligament coming down. So cranial and caudal support is provided by dorsal and palmar radiocarpal ligaments. And then on the palmar surface, there'll be the ulnar carpal ligament. There are small intercarpal ligaments between the carpal bones, but these are not something we worry too much about in a surgical context. So on X-rays, just to kind of highlight what you'd be looking at always on orthogonal view. So here on your DV view, you'll have the radius, and then you have the ulna. We have our radiocarpal bone, and we have our ulnar carpal bone. And then, here on our lateral side, we can see the accessory carpal bone. And then obviously they are the metacarpals. It's important when X-raying your patients that you take a stress view. So, what we can do normally is just have them laying flat. Whereas when we stress that antebrachiocarpal joint, we're able to evaluate the structures a bit better. The difficulty with looking at the bones of the carpus and the tarsus is that there's a lot of superposition, especially in the tarsus. Here, I have the luxury of having a radiology department. So they kind of just give us evaluations of our X-rays. It makes me a bit lazy. It makes my senior surgeons who I report to not have to do so much work. But for you guys, the audience, especially in a general practice setting, you may not have that luxury. So it's important to have good radiographic technique and to understand what are the structures you're visualizing, especially when you are looking at fractured bones, because it can be very difficult. And it's not something to be ashamed about, because I'm practicing with surgeons that have been board certified and have been practicing. My senior surgeon, he's been teaching for 40 years. He's still, we will still sometimes have doubts about fracture lines, the degree of comminution of some fracture fragments. And we kind of leave that up to the radiology department. We will get a radiology report. And so it makes us a bit lazy. Now, going to the tarsal joint, the talus is the only bone that will articulate with the tibia and fibula. So it's important to remember that, especially important, although I'm not going to present on it, if you ever have to disarticulate the joint, keep this in mind. The area you're going to be concerned with is the talus. I once had a goat, which I had to disarticulate at the tarsal joint, and I probably wasted 20 minutes of surgery time messing around with the calcaneus when I could have just easily, if I had known my base anatomy, I could have just easily disarticulated the talus, and then a lot of time would not have been wasted, and it would be better for the patient due to decreasing anesthesia time. The central tarsal bone articulates with all the tarsal bones. And so it's really important to keep this in mind. This is something I'll touch on kind of at the very end of my presentation, but it acts as a buttress and stabilizer for the tarsus. You'll see a lot of times with, especially greyhounds, fractures and luxations of the central tarsal bone presents heavily in our greyhound population. When the central tarsal bone goes, oftentimes they'll put more strain on the calcaneus, we'll find. So sometimes there'll be sometimes our patients will present with fractures of the central tarsal bone as well as fractures to the calcaneus. So it's really important to kind of keep in mind, there's 7 bones that make up the tarsus. It's a lot to kind of keep in mind and then evaluate radiographically and then kind of pay attention to. So if there's any bone in the tarsus that you're going to pay attention to, try and pay attention to the central tarsal bone. The joints that make up the tarsus. So we have the tarsocrural joint, which is the joint of the tibia coming down and attaching to the talus. We have the calccanial joint. So we have the joint between the talus and the calcaneus. And if you remember, the sustentaculum tali is where those, I believe, the deep digital extensor kind of comes down and articulates with. And then we have the proximal intertarsal joint, which is what we would call a combination of our calcaneoquartal joint, so our calcaneus and our fourth tarsus, as well as talocalcaneocentral joint, which you can see right here. And so these two joints in tandem form what we call the proximal intertarsal joint. And then we have the distal intertarsal joint, which is, it's also called the centrodistal joint, which is just the joint of the central tarsal bone with the distal tarsal bones. And then we have the tarsometatarsal joint, which is the joint of the distal tarsal bones with the metatarsals. Also, kindly, if I'm still speaking too fast, let me know. It's a bit of a habit for me, just due to my background, and I apologize for that. So ligaments of the tarsus, we have the medial collateral ligament. So like I touched on before with the talking about the ligaments of the carpus, the ligaments of the tarsus are pretty characteristic. The long part of the medial collateral ligament goes from the medial malleolus, and then it inserts onto the first tarsal bone and the first and second metatarsals. The short part divides and inserts onto the talus and the first tarsal and metatarsal bones. The lateral collateral ligament, the long part of which runs from the lateral malleolus to the base of the fifth tarsal bone, and in the interim, it attaches to the calcaneus and the fourth tarsal bones. The short part, collateral ligament divides to the tuber calcanei, and it also attaches to the talus. As well as on the plantar aspect, there'll be plantar ligaments, and then on the dorsal aspect, there'll be dorsal ligaments. The dorsal ligaments aren't so well developed compared to the plantar ligaments. So if you think about it, you have collateral ligaments, although the plantar and then the dorsal aspect are not technically called collateral ligaments. Sometimes they're referred to as interosseous ligaments. It mainly depends what textbook you're reading. I believe in the Indian context, most of us have grown up reading Sis and Grossman, which is much older textbook, so the verbiage may vary. But one thing to keep in mind is like the way that these four kind of on the medial aspect, the lateral aspect, the dorsal aspect, and the plantar aspect help to stabilize that joint. And then we have the tendons of the tarsus, and So tendons lying on the dorsal surface of the tarsus are the flexors and of the tarsus, and they're the extensors of the digits. The tendons laying on the plantar surface are the extensors of the tarsus, and they are the flexors of the digits. So the big tendon to really keep in mind here is the common calcaneal tendon, also known as the Achilles tendon. And it's important to keep in mind that it is joining up of 5 tendon sheets. So we have the gastrocnemius coming from the gastrocnemius muscle. It attaches laterally to the calcaneus. And then we have the combined tendon, which is anastomosis of the tendon sheets of the biceps femoris, the semitendinosus, and the gracilis muscle. And this comes down and attaches medially onto the calcaneus. And then we have the superficial digital flexor tendon, which it kind of covers the entirety of the tuber calcanei right here, and it attaches to, and it keeps going down to the plantar aspects of the second phalanges and kind of spreads out and then attaches to them there. And so what you'll see is that think of the gastroc and then the combined tendons as coming down, attaching on calcaneus, and the superficial digital flexor as something that, while also being part of this common calcaneal tendon unit, if you look in the literature, oftentimes it'll be described as a common calcaneal tendon unit or the Achilles tendon unit. Think of the superficial digital flexor as something that is enveloping and kind of bringing everything together in a unit in a visual sense. Also, we have the deep digital flexor tendon. It's basically, there's 2 parts to it. There's the part made up on the lateral side. Sorry, this is supposed to be flexor hallucis longus, and then on the medial side by the flexor digitorum longus. Another tendon to keep in mind, just for your surgical approaches onto the medial aspect, is the tendon of the cranial tibial muscle. This actually took a long time for me to figure out because it's just not properly given in any of our anatomy textbooks. My surgeon would always chastise me for this, but and that's because to the fact that the muscle actually starts all the way up on the kind of tibial tuberosity, but then if you see the tendon, it comes down and ends here on the medial aspect of the metatarsals, and that's just something that I always found hard to keep in mind. So radiographic appearance, again, on orthogonal views. So we have the tibia, the fibula, and, you can see what I mean by superimposition. I cannot fault anyone for missing fractures or degrees of luxation to the tarsal joint. It can be very tricky, and even to this day, like I was saying earlier, a lot of the surgeons I work with will say that, okay, they see this, but they're not 100% sure as to what all they are missing. And so we really do rely on our radiology department to kind of check all the boxes for us. So we have also the calcaneus here. And then here you can see on the lateral view, the subsyntachial tali kind of highlighted. The talus is here on the medial aspect. We have the fourth tarsal bone and then the central tarsal bone. So you can see how the central tarsal bone kind of sits flat here on the lateral aspect. And that's, again, highlighting the importance of the central tarsal bone. You want to evaluate to see if it has popped up a bit, because that's where you'll see a degree of luxation or subluxation. And then you will also want to look for any visual lines here to tell you whether or not there has been a fracture. Oftentimes it will present as a slab fracture. So that's a fracture that's just kind of running parallel to the dorsal surface of the bone here. Sometimes you may see it a bit more comminuted depending on the type of injury you're dealing with. Keeping in mind that, this is mainly going to be happening with dogs that are dealing with a great degree of force coming in a sagittal direction to the limb. So it's usually not something you may see with your typical road traffic accident dogs. It's going to be something you see more with dogs that are maybe doing a high degree of high intensity running or anything like that. So in the Indian context, I mean, coming from Chennai, I'm just thinking of dogs running on the beach, or maybe in hill stations where you have dogs running on very kind of variably hilly surfaces. And then of course, we have the metatarsals down here. So just things to keep in mind before we go into individual presentations of how distal limb injuries can present. Always take orthogonal X-rays. So, make sure you're not just taking one view, but you're having a DV view or dorsal palmar or plantar view, and then you have your lateral view. That way you can effectively evaluate it. If you go look at some of these old radiology textbooks, there was a very famous radiologist named Joe P. Morgan, and he actually says that, in injuries or suspected injuries or pathologies involving the carpus or the tarsus, he highly recommends that you take 4 views, right? So you have a right lateral, a left lateral, and then, kind of like a craniocaudal and a caudal-cranial view. CT does get performed sometimes, but we are a rather, being a teaching hospital, we try to be cost conscious with our clients, so we rarely elevate to CT unless it's a very prized working dog, and there's a degree of doubt even with the radiology department on how the I guess X-rays are presented. Now, the decision for antibiotics, I remember in the Indian context, it was always, we gave pre-op antibiotics, intra-op antibiotics, and post-op antibiotics were almost always a given. We rarely will use antibiotics here, unless obviously there's an open fracture, in which case, at that point, antibiotics are justified. If we believe there's going to be a large degree of surgical time, then we would start intra-op antibiotics. We rarely will dispense post-op antibiotics, and these being orthopedic procedures, we often go for our first-generation cephalosporins. So cefazolin is always given IV intraoperatively, and that's just due to the good amount of penetration that has with orthopedic injuries. I don't know how readily available cefazolin is in India. I do remember when I was there 3 to 4 years ago, I did have some general practitioners tell me that they had some difficulty getting first-generation cephalosporins. Hopefully that's not the case, because I believe, at least in the human side, orthopedic surgeons would still be using cefazolin kind of the world over. That's the go-to. And so if you can try to get first-generation cephalosporins is good, and therefore we have judicious use of antibiotics. And, in terms of decision of post-operative antibiotics, as long as you're able to maintain sterility and you don't have a really long surgical time and you don't have what is an open fracture to begin with, there shouldn't be too much justification for using antibiotics post-operatively. There have been times in which we will have patients come back and present with what we believe to be wounds or tracking wound or kind of like infected tracts that go down to our implants. But oftentimes this is kind of exclusively in greyhound, and that's just due to the thin amount of skin there is on their distal limbs. So by the time you put a plate on and stuff and you close skin, you're closing under a great deal of tension. And we're kind of just trying to maintain the implant at that point for us to provide healing time. And oftentimes we're taking the implants off. So sometimes these patients may present with a degree of infection, in which case we'll culture and send for culture and sensitivity. And then, usually we'll end up putting them on amoxicillin or amoxicillin clavulanic acid and send them for culture sensitivity. And if something comes back and is resistant to amoxiclav, then, we will escalate up the kind of chain. But it's just such a rarity, so I wanted to highlight that. Another thing we're doing is, so through our anesthesia department, they'll often put regional blocks. So for injuries to the carpal joint, they'll do RUM blocks, so blocking of the radial, ulnar, and median nerves. They like to use ropivacaine just due to the long duration of action. These will be ultrasound guided blocks, and ropivacaine is often used just because that while we have to make while the patient won't be able to have full control of the limb, so we have to worry about them knuckling, up to 8 hours from the administration of the block. It provides a deal of analgesia, and therefore we can decrease the amount of opioids and other analgesics that we're using. Another thing we need to think about is anxiolysis. Sometimes our patients are very anxious in hospital. It's a very strange environment, strange smells, strange noises, patients coming in and out, the emergency cases coming. Massey University, we really rely on our students. Just the staffing numbers much, much smaller compared to a North American or subcontinent context. And so due to this, having to rely on the students, they're not always up to par with what you would want them to do, and they can kind of end up being a bit too noisy. So all this contributes to a great amount of anxiety to our patients. And this is something that we're really worried about in a post-operative sense, because we don't want our patients crashing around in their cages or in the kennels or wherever they're being housed. We want them to be as restrained as possible in a humane way so that they can exhibit the stereotypic behavior. So for anxiolysis, oftentimes we will give them gabapentin or trazodone. Sometimes in combination if they're a very anxious patient. Another thing we need to think about is post-operatively owner compliance. A lot of these injuries will need to be bandaged and splinted. There's going to be a long degree of cage rest required, many bandage chains and splint care. New Zealand being a southern hemisphere island that's basically close to Antarctica, the weather is very variable. It rains a lot here. So oftentimes things are very wet outside. And so we're in India where we have the benefit of the monsoons and predictability with rain. Unfortunately, we don't have too much predictability. It'll be sunny one moment and 2 hours later it'll be raining. So we also have to worry about the bandage getting wet, which sounds like a silly thing, but it's actually a big, big problem. Another problem I've encountered a lot with my patients is male greyhounds. When they go to urinate, oftentimes they'll end up urinating on their bandages as well, be it forelimb or hind limb. And so we'll have to do a lot of bandage changes, or patients that have been discharged from hospital will often have come back because they've urinated on their bandage. And so all these things just kind of adds up, because every bandage change and everything, done under sedation and stuff, adds up in cost, adds up in human resources on our part, and then just the amount of things we have to do with the patient. You're also looking at long post-operative healing times, at the carpal joint, up to 12 weeks. And then at the end, and for the tarsal joint as well, but if we were talking at the kind of tarsal joint or the antebrachial carpal joint, it's up to 30 weeks oftentimes that you have to be thinking about until you have proper bony union. And this is mainly due to the fact that, and this is the complexity with distal limb injuries, that if you go back to your basics of fracture healing, there's a small amount of soft tissue just on the distal limbs. If you think about at the carpus and at the tarsus. And because of that, there's a low degree of vascular supply to these bones, as well as a lot of avascular structures there. Many places you're ending up with just a lot of ligaments and tendons. And so there's not going to be a high vascular supply to this bone. And due to that, there's just going to be that less degree of kind of mediators of healing that are needed to facilitate that. And so you just have a long degree of postoperative healing, and then you have a increased chance of postoperative complications. And these are all things that the owner also needs to be made aware of before they engage in or I guess comply and offer their kind of willingness to go ahead with any surgical management, because they really do have to be aware of how complicated things can get postoperatively. And then there's always the potential need to remove the implant, just due to the fact that on the distal limbs, there's not much area to close with. You're closing under a lot of tension. Oftentimes, to close skin, you may have to do some type of tension relieving suture patterns or incisions. We haven't had to do any flaps or anything too crazy like that I know of. But the implant may need to be removed just to the fact that oftentimes if you are doing anything, that requires plating, the plate will be just pressing against the skin and may create some type of pressure sores and wounds. And also in conjunction with just bandaging, you also have to be aware of just how your bandages are being placed. Sometimes the bandages themselves can create abrasion wounds in these distal areas. Oftentimes at the kind of lateral and medial bony prominences, the carpus and the tarsus, but also kind of on the, I guess, what the second and fifth metatarsal kind of joints are around, I guess, between the second and third phalange. So coming into our carpal injury treatments, the main kind of go-to here and thing I want to kind of emphasize is pancarpal arthrodesis. This is something that you're kind of going to, or at least we here at Massey, usually do to treat our carpal injuries that involve I guess, need for fixation. The main reason for this is that we're trying to immobilize the joint. Sometimes it can be very hard for us or any practitioner to go and repair individual structures. So what we mainly deal with is we try to repair to the best of our abilities any tendons or ligaments. And then when it comes to the bone actuality, what we're doing is we're basically going in, using a high-speed burr, we're just removing all these articular cartilages. So we're really opening up all these joints, right? So in terms of the carpus, we have our 3 joints, opening up all the joints between every individual carpal bone, burring out the cartilage with a high-speed burr, and then we will pack it with bone graft. And obviously the going back to the base principles, what we're trying to get with this bone graft is that we're trying to promote the kind of cytokines and the mediators that would cause bony union, while also trying to provide a matrix for which bone can grow upon, and we're also trying to increase just that kind of formation of bone. And then so that's done to kind of create an arthrodesis of the joint. And then this is supported by plating. So there are specific plates made. And so we will use these plates to stabilize pericarpal arthrodesis. The width of the distal aspect of the plate is tapered. So as it goes from proximal to distal, so going down from the radius down onto the metacarpals, it kind of tapers down. And so this is done to minimize tension. And what we're trying to aim in terms of angulation of the limb is 5 to 10 degrees. 10 degrees is a pretty normal degree of angle for the carpal joint norm at rest. So that's what we try to maintain. And so if you want to ask the question of, okay, well, what type of return to function do we get with pancarpal arthrodesis? Going back, that antebrachial carpal joint is one of the high flexion joints. So you're going to lose a degree of that, but the animals should be able to compensate by having flexion and extension at the elbow and the shoulder to be able to have good quality of life in terms of its ability to work. And like bearing in mind that this is things that we're doing to working dogs here in New Zealand, farm dogs that are very valuable, very vital to the farmer's kind of livelihood. And this being the primary industry in New Zealand, this is something that we consider to be very appropriate. When plating, it's important to first secure the plate to the radiocarpal bone first, and then usually onto the third metacarpal, and making sure that you have a good amount of purchase in the metacarpal. So you want to slightly cover more than 50% of the length of the metacarpal bones in order to avoid any complications going forward. And then in terms of repairing ligaments and tendons, we usually use a Kessler locking loop or a tree pulley loop. Tree pulley loops are best. They're a bit stronger, but they are a bit better for round tendons, whereas a Kessler locking loop oftentimes, at least the surgeons I work with, they would opt to use this to repair what they consider to be flatter tendons. Here are the knots on the inside, where here the knot lands on the outside. And basically, I know this kind of drawing that my professor have drawn for me can be a bit difficult to follow, but the way one of my surgeons says is like, just think that you're taking 3 nice bites of tendon and then opposing them. So the first injury I want to kind of talk about is carpal hyperextension, right? So or hyperextension. And so here, what we have is basically separation at the base of the accessory carpal bone is separating from the metatarsal bone. And so there's rupture of the fibrous tissues that support the flexor surface. And so this is basically the flexor retinaculum and the palmar carpal fibrocartilage. Usually the surgery we do for this is pancarpal arthrodesis. I do think that there are some people out there that would try to splint this, but you're just not going to have enough stability. Stability, and then at that point, like I said, for everything, pancarpal arthrodesis is your safest option. And like I highlighted earlier on that slide, I don't know if you can make it out, but you can see how the plate kind of tapers a bit more to the distal end compared to on the proximal aspect. And then obviously you can contour your plate to fit the bone. Another injury that we can always highlight on the carpus is antebrachial carpal joint luxation. This would be fairly easy to diagnose. Your patient will have a lot of instability. On X-ray, there'll be clear subluxation or luxation of the joint. And this can be variable in how it presents due to the fact that it can mainly depends on what ligaments are gone, we have all short radial and ulnar collateral ligaments, but also on the dorsal and palmar aspect as well. Think about those ligaments. And it's really hard to repair individual structures. None of the surgeons here really bother about that. Basically, what they do is they try to repair viable ligaments with a tree loop pulley suture pattern. And then oftentimes the joint may be stabilized with a pancarpal arthrodesis at that point too, if too many ligaments seem to be gone, and you have a lot of these interosseous ligaments as well breaking. Those are very small structures that cannot be recreated or fixed or reopposed. So at that point, it's a bit safer to just kind of arthrodese the joint. The only bone in terms of that you have to deal with in the carpus that usually will go is the accessory carpal bone, right? That bone that sits there on the palmar aspect. It's very common in racing greyhounds, and like I said, due to the anti-clockwise nature of racing, it will always present usually in the right forelimb. And kind of treatment options here really depend on the size of the bony fragment. I think I've only seen one of these cases thus far here at Massey. They don't come too often, but oftentimes what can be done, and depending on the degree of comminution and the degree of the fragment that remains, is they'll try to reduce it with a screw. So yeah, a 2 mm screw, but they try not to lag it in place usually. Sometimes with the one case I have seen here, we will just excise the bony fragment out, and then again pancarpal arthrodesis. It's just a very easy way to deal with these distal limb carpal injuries. Going to tarsal injuries, this is kind of the area that I have more exposure to. This is the area that my research currently deals with. And that's mainly to do with partial tarsal arthrodesis as compared to pan-tarsal arthrodesis. The idea being that this is not supposed to be a true arthrodesis of the joint. We are rather just trying to stabilize the joint, and that's something I'll go into further. This is a case I believe we did maybe 2 weeks ago. So an injury that's very common to the tarsal joint is injuries to the collateral ligaments. Sometimes on the medial aspect, on the lateral aspect, the patient will present with a degree of varus or valgus, depending on which ligament has gone. And treatment is very simple. Again, going in, reconstructing the ligament with a tree-lid pulley suture pattern, and then to stabilize the joint, what we'll do is we'll drive a calcaneotibial screw in. So this stabilizes the joint in where it could bear weight, but it's not able to have a high degree of flexion or extension. And so we'll keep this calcaneotibial screw in for as long as we can, honestly, until that we're satisfied that, that there's been a degree of healing. Reminding that tendon takes a long time to heal because, as well as ligaments, they take a long time to heal because the avascular structures and included the tissue envelope, they don't have a great blood supply. And then, to get back that degree of collagen, and, even once you have like proper healing and apposition, it's going to take upwards of a year to even return to kind of like 70% of tensile strength. So a lot of times we will be repairing these with not with silk, but a non-absorbable suture, although not technically non-absorbable, something like polyamide. This is a study that was done here in terms of using temporary calcaneotibial screws. The screw can and will be removed, but oftentimes we try to keep it in there for as long as possible. Oftentimes we even try to keep it in there until the screw itself ends up breaking, due to the kind of cyclic loading of the joint. Eventually these screws, after around, I believe it was 10,000 to 50,000 cyclic loading. So if you think of the kind of dog going like this 10,000 times, roughly around that point, sometimes these screws will break. Oftentimes they break in half, which is why we try to advance them to where we have a good amount that has bicortical approaches on the tibia. And so we'll just remove the palmar portion, and then we'll pull out the cranial portion through an incision made on the cranial aspect of the tibia. Another thing that can be done, and this is something that actually I mainly seen done in Chennai, is using prosthetic imbrication. So using screws and washers, and then therefore trying to reconstruct so this would be good, I guess, if you had a large shearing injury or something and you had lost the collateral ligaments, then this can be done in which you're essentially reconstructing what that normal range of motion would be. We don't do this much here at Massey, mainly because we feel that due to the fact that these implants can sometimes rub against that joint and therefore cause a lot of wound complications going forward, where you have these kind of screw heads that are just rubbing against the joint surface, or I mean the joint surface in the skin, and sometimes it predisposes to having a lot of cutaneous wounds post-operatively, which is why we have kind of published and are really advocating for calcaneal tibial screw replacements, and then reconstructing the ligaments as much as possible. Common calcaneal tibial rupture. So again, dogs will usually present in a plantigrade stance. On X-rays, you'll see a great amount of soft tissue swelling, and then it's usually obviously very visible to you as well. Just on palpation, there'll be a grade of soft tissue swelling on the at the aspect of the calcaneus. Sometimes these can present as avulsions of the calcaneus, and so sometimes we would have to not only repair the common calcaneal tibial unit, common calcaneal tendon unit, but we'll also have to go in and repair where slab fractures of the calcaneus, and usually that would be done through pinning and tension banding, although sometimes plating on the lateral aspect is performed. But this is actually a patient that's still in hospital. We did this patient just maybe, I believe, on Monday of this week. But this is a patient's working dog that presented and for a rupture of the complete rupture of the common calcaneal tendon. And so again, we went to I believe it was a Kessler locking loop that was elected for this patient. No, sorry, a tripoli locking loop was elected, and then placing a calcaneal tibial screw to then again immobilize the joint. Transarticular X fixation is you kind of a better way to immobilize the joint and to allow time for the common calcaneal tendon unit to heal. The difficulty is that then you have to do extensive bandage care, and that's in the New Zealand context where we have farmers who are bringing their dogs from anywhere from 2 to 5 hours away, sometimes even up to like 8 hours away by drive. It's difficult to and we cannot always rely on their local referring veterinarian to always do the proper amount of banding that's needed for these external fixators. So we often don't opt for these, but there are some nice, apparently, external fixators where the actual joints have a bit of leverage to where, for the purposes of rehabilitation, they can be loosened, and then there can be flexion and extension allowed in a craniocaudal direction, which I believe some specialist centers in private specialized centers in Australia and New Zealand, mainly in Auckland, which is the kind of big tier 1 city here in New Zealand, opt for. Us being a teaching hospital that serves a mainly farming population, it's a bit expensive, and due to complications of postoperative care, we usually don't elect for that. But it is a good thing to keep an eye out for if you are having a clientele that can afford this, and then you are able to provide the kind of postoperative rehabilitatory services or guidance to your clients. Another thing to keep in mind is the use of glucocorticoids. In patients, for example, I believe this patient has some skin issues, so was placed on prednisone and much prior to obtaining the injury, but there's a fair degree of literature on the human side and now coming up on the canine side. The veterinary side. I believe this was published in VCOT, the Veterinary Journal of Veterinary Comparative Orthopedics and Traumatology. as to how it can cause apoptosis of tendon cells. And so therefore we have weakening of our tendons. So it's just something to keep an eye upon. And this dog actually presents with bilateral tendon weakening of the tendon. So while the tendon on this right hind limb is gone, there's a high suspicion that the left leg will go to at some point in the future, and the owner has been warned about this, especially given that the dog is already on prednisone due to that being prescribed by the referring vet for its dermatological problems. And in those contexts, this will often present bilaterally. Calccanial fractures. So this is often some things I see a lot of my racing greyhound patients. Sometimes they can be incomplete fractures, in which case we will just go ahead and pin and tension band. Sometimes when they are slab fractures, so again, they're running kind of parallel to this surface, then plating plus or minus tension band, but often plating is sometimes ensued. Sometimes the surgeon may opt to try to reduce by lag screws and then plate, kind of surgeon preference. Now, this is the thing that I'm dealing with a lot. Again, central tarsal bone fractures. This is something we see a lot in our racing greyhounds. It's something that we see a lot in our police dogs, in our farm dogs. This was a study conducted by the Working Dog Center here at Massey, just in terms of long-term outcomes for partial tarsal arthrodesis. So the way this would typically be tackled, and if you look at any orthopedic textbook, they would offer for a pan-tarsal arthrodesis. So again, this is where you're going into the tarsal joint, between all those 7 tarsal bones and everything, breaking open each individual joint using a burr. You're burring out all the cartilage, packing it with bone graft, and then holding everything together with a pan-tarsal arthrodesis plate, which would usually span the length of the kind of distal tibia coming down onto the metatarsus. What we're trying to do here at Massey, and what we've published and are in the works of publishing again on, is using just a 2.7 locking plate, and using it for partial tarsal arthrodesis, where we're just kind of stabilizing the joint. Here you can see the central bone. We just using point-to-point reduction forceps will reduce the fracture and then place a lag screw. If we can get a lag screw in to just offer reduction of that central tarsal bone fracture, and then we will do a partial tarsal arthrodesis without any bone grafting to stabilize the joint. And the dogs have actually done very well in this so far. Only thing is same complication that we get with our pan-tarsal arthrodesis, which is where we have a fair degree of, you can just see how, I don't know what tension this plate is in terms of the skin covering. And it's very hard to get apposition of all that soft tissue, and you are placed with a great degree of tension. So main complication we see with this is sometimes there may be implant failure if we're not able to if there's been poor owner compliance or poor stabilization of the leg with splinting and bandaging. But oftentimes it's due to the fact that we're having open wounds form on the skin, and then that creates a draining tract down to the implant, in which case we're dealing with then an implant associated infection, at which case we have to prescribe antibiotics until we have successful bone union, keeping in mind that it's going to be a long time for a proper union to occur. So these dogs are on antibiotics for a long time until we're satisfied with the degree of union, at which point in time we would stop antibiotics, remove the plate, and then send for culture and sensitivity. Lastly, we have metacarpal and metatarsal fractures. These are fairly easy to deal with. The first thing you need to keep in mind is you don't always need to deal with these surgically. I think in the current climate any case that doesn't have to be taken to surgery is always viewed as favorable by everyone, but it's also in the interest of the patient to not and not have our patients go under anesthesia and then the pain of surgery and then the postoperative analgesia that needs to be administered. So if you have the fifth and second metatarsal often not fractured, and you just have a fracture of the third and fourth, your medial and lateral metatarsals will kind of function as a splint itself. So splinting of the metatarsals or carpals actually has a fairly good outcome. That being said, here at Massey, we usually see dogs that have had fractures of both the second and fifth metatarsal. So at that point, we will go for dowel pinning, which is basically where we take K wires. And so we advance a bit in to usually the proximal fragment and then under a great deal of tension. So, these dogs will always be in hanging limb, obviously, before surgery to fatigue the musculature. And then we don't often use any muscle relaxants, but sometimes benzodiazepines may be administered, so that we're able to then take the distal fragment and attach it on to the K-wire and have some degree of reduction there. Sometimes if that's not possible, what can be done is, a drill will be used to kind of like create a little bone tunnel, and then we will advance the pins and have it bounce off the kind of, I guess, what you could consider to be the plantar or palmar cortex, and then kind of advance the pin in. Another thing that's been done by Fitzpatrick Referrals, which is a pretty famous referral center in the UK. Noel Fitzpatrick is a relatively famous orthopedic surgeon. He has this thing called the spider, where basically it's an external fixator where they've advanced all these pins in, and then just using epoxy, they just kind of hold everything together. I've never seen this done. This is the paper where it was referenced from. Not exactly sure what the postoperative complications that you'd have to deal with, although I can imagine bandaging and having postoperative care of this patient, owner compliance is going to have to be of a high degree. Here at Massey, we obviously just go for dowel pinning, and that plus splinting is usually more than satisfactory. And given the working dog nature, these dogs are obviously out there on farm fields where it's a very muddy environment, police dogs there, having to deal with all types of environmental factors. So our ability to kind of we rarely will go for external fixators here, only if deemed necessary, usually with very complex kind of transarticular and articular long bone fractures. Yeah, that's the essence of what I have to present for you today. This was supposed to just be a kind of preview into how we deal with the distal limb injuries that present to us here at Massey University. I'm happy to take any questions, although bear in mind it is 3:30 a.m. in the morning here in New Zealand, so it's quite late or early for me. Thank you.
Thank you, Dr. Suriya, for your elaborative, in-depth information about the, limb injuries. Starting with carpal injury, tarsal injuries, common calcaneus tibial fracture management, and the calccanial fracture management, and metacarpal metatarsal fracture management. And now, there are a few questions. Maybe you can see in the chat box. Electrocuted cat hind limb, how to manage is showing necrosis. Should we do amputation or should we manage with the bandaging?
I Actually, that's something that's more kind of critical care that maybe Dr. Chandrasekar himself could give more elaboration on, because not to be too, I guess, how to say, disrespectful, but this is something that would present more to our emergency and critical care department in
Yeah,
terms of
okay.
how I haven't dealt with the electrocution injury and how we would use glucocorticoids to manage that. If this was to present to me, the first thing I would evaluate was what the tissue viability looked like, and then I would, if I if it was just handed to me, I would approach it from a neurological standpoint of doing a full neurological examination and seeing what is the viability of the limb. But I haven't dealt with an actual electrocution injury in years. So, Dr. Chandrasekar,
Yeah.
what are the complications that we usually deal with in electrocution injuries?
You see, we'll hear from Sivasankar, then I'll come back to you. Dr. Sivasankar?
Okay.
Yeah. Good evening, everyone. I think most of the electrical injuries for a cat, if it is so intense, I think it's better to go for an amputation than go for a bandaging, because the healing pattern when you do an amputation ASAP will make the cat more comfortable than wait for a long time for a bandage and so on and so forth. And Surya, I have a small request that do you guys do ultrasound of the tendons you described?
Yes, although only when not usually with our distal injuries. Usually we're doing ultrasound studies of tendons mainly with um, shoulder lameness that shoulder. We did a biceps tendon tenotomy earlier this week, and so these type of patients are the ones that we're usually sending to ultrasound. As for the distal limb, usually depending on how they present and kind of to which way we have luxation or subluxation, we can kind of have an idea of what we believe or localize where we believe the injury is. I guess ultrasonography would be very useful in perhaps evaluating the degree of viability of tendon, perhaps. But that's mainly something we will mainly do for shoulder injury, shoulder lameness is where we are repeatedly sending dogs for ultrasound studies.
Thank you.
Thank you, Dr. Sivasankar and Surya. And another questions by Dr. Madan. How we can manage bilateral hip dysplasia in large breed young dogs?
So if the dog is young enough, less than 5 months, months of age, and you've been able to take proper stress radiographs of the pelvis and then under sedation, then juvenile pubic symphysis is probably your best way and also the most economic way. It's electrocardiogram machines are of high quality in India and they're very affordable. One difference between India and New Zealand is, as well as Australia, is that things are very expensive. It's a very isolated part of the world. So in India, you're, as a practitioner, blessed with having high quality instrumentation that's available at nominal cost. Whereas electrocardiography is oftentimes a lot of general practices don't even have that. But if you have access to that, and it's a young dog below 5 months of age, and juvenile pubic symphysis is often preferred. After that, an old school approach would be doing a triple pelvic or double pelvic osteotomy, although that's not done much. Depending on how the dog is presenting with hip dysplasia, your femoral head and neck ostectomy can always be performed. Here at Massey, if these are dogs that are truly not able to be managed and have really dysplastic hips, especially, I know you're talking about a young dog, but depending on if they are predisposed to having some degree of osteoarthritis, then we go for total joint replacement. So we are doing total hip replacements here. especially if they're large breed dogs.
Okay, Surya, thank you. The last question is, we will allow you to sleep. Please explain pain management protocol in cats.
Okay. So sorry, I should have touched on pain management on all our patients. So I'll start with what I would do for my canine patients, and then go ahead for our feline patients. So obviously, we tried to get our anesthesia department is actually very good. Another thing I should have mentioned, just for distal limb injuries, overall, you're going to have a lot of bleeding. Hemostasis is very important. And the reason I want to highlight this is we have a very good anesthesia department here at Massey University. And so they do a too good job of managing hypertension. So our patients actually have very good blood pressure, which unfortunately means more bleeding on our end of the table on the surgery side, just because the intraoperative blood pressure is so well. But anesthesia, they'll do these local blocks, and then intraoperatively they'll be running usually CRIs. So we don't usually constitute a bag with, say we want to run fentanyl, lignocaine, and ketamine. Sometimes in general practice, even in the US, it's often put everything into one bag and run that. We will run everything as an individual infusion on individual syringe pumps. That way, we're able to titrate the effects that we want to gain from each drug. So oftentimes, if we have them on an opioid like fentanyl or methadone, then we will kind of titrate down the ketamine CRI and keep the opioid going for up to 24 hours or at least 12 hours post-operatively. Usually we don't have any alpha 2s running on a CRI too long for our patients unless we need it for some degree of sedation if they're a very fractious patient. And then post-operatively, they will be getting an NSAID. So we use a lot of carprofen or meloxicam. Meloxicam comes in a very easy oral suspension here, which is honey flavored. So it's both our patients, both canine and feline, really like that. So we find owner compliance is better and that owners are able to administer it and the patients are able to take it without any difficulty. Carprofen, we have some flavored tablets, but they're a bit more expensive. So we oftentimes, for our farming clients, try to offer the non-flavored tablets, but then the degree of compliance, some of these dogs or cats, if they're not happy getting pilled, it's difficult. Another thing we use, I know you asked about cats, but I want to highlight the use of paracetamol. Paracetamol is very good, especially in patients where we're not able to give them an NSAID. Even preoperatively, we'll start them on paracetamol. We don't usually give NSAIDs preoperatively just because the anesthesia department isn't too happy due to the fact of managing blood pressure if we give that. So we always reserve our NSAIDs for postoperative administration only. But paracetamol at oral doses, usually between 20 to 30 mg per kg, is very good for dogs. Obviously, it's contraindicated in cats. Make sure if you are dispensing Panadol to your patients that you're making sure that there's nothing else combined with it. You want to make sure that it doesn't have any other medications in conjunction. For the longest time, paracetamol was not openly accepted in the community. It's still looked down upon a bit in terms of literature in North America. I know in the UK, in Europe, they've eventually brought on board what the pharmaceutical company has done in the UK, so that paracetamol is a very cheaply available drug, which is why we so often advocate for it here in New Zealand. We have a very kind of working class population. But in the UK, what they've done, just so that you can't just go out and buy human paracetamol, is they've added a small amount of codeine into the the pharmaceutical kind of mixture. And that way that the whichever drug company that has gotten this license through a clinical trial in the UK is able to market it as paracetamol that is licensed for veterinary use, but off-brand paracetamol that you normally get, we get 500 mg tablets here, is very good. And then oral suspensions are also good for cats. It's going to be in the intraoperative period, like I said, local regional analgesia with opioids, and then oftentimes being run on a CRI. so methadone or fentanyl. And then sometimes what we'll do is we'll opt to keep them on, we'll just keep them on either methadone, oftentimes morphine, Q4, so at 0.2 mg per kg, subcut or IV. Every 4 hours, we have students or nurses kind of pain score them on using the Glasgow pain scale. And so we set a threshold of usually anything that is about a 5 to 6 out of 20. So if you go and look up these pain scales, they're a pretty good way to kind of consistently tell if your patient is painful or not. For cats in particular, there's a grimace scale, which kind of looks at the way that the ears, the muzzles, whiskers, and the overall mentation of the cat is presented so that we're able to gauge relatively objectively how painful the cats may be, and then have a basis on which we are administering them the opioids. In the surgery department, we tend to be more conservative with our opioid usage compared to our critical care and ICU staff, which is more liberal with their opioid usage because they're the ones who see the patients. They're the ones who take care of our patients. Our patients are recovered post-operatively in the anesthesia department, and then they're sent down to the ICU. So there's always heavy advocacy for opioids usage from the ICU staff. I try to cut them off opioids as soon as possible. That way, we're able to discharge them from hospital. Our patients are always happier when they're out of hospital, and the sooner we can get our patients home to the owners, the better. In a general practice setting where you're going to want probably maybe want to do outpatient procedures, or maybe your hospital is not 24/7 or does not have the ability to monitor your patients intensively postoperatively in hospital or for a 24-hour period, that I think it's very litigious to send them home on a dose of opioids. And cats, buprenorphine, even the IV constituents that you get, you can dispense a lot of buprenorphine to your owners and instruct them to give it sublingually. Make sure that they're not swallowing the buprenorphine, but buprenorphine given sublingually has very good take up by cats. It's not good in dogs due to the pH of the saliva. So buprenorphine is great in cats. I always try to de-escalate my patients off of full mu agonist opioids such as morphine or methadone down to buprenorphine. You have to keep in mind that the agonist antagonist way that buprenorphine works, it has a high affinity to these opioid receptors. So if you are going to go on buprenorphine and find that your patient is still very painful, that's something you have to worry about because for roughly 8 to 12 hours, you're not going to have full uptake of morphine. Buprenorphine is going to outcompete some of these full mu agonists in terms of affinity for those opioid receptors. So if you think your patient is not very painful to where they need morphine or methadone, then I highly recommend buprenorphine. And then it's also a great way to send it home with the owners. A lot of patients, I have a lot of feline maxillofacial fracture patients, and I always end up sending them home with at least a couple days worth of buprenorphine. Keeping in mind that buprenorphine being an opioid, I'm not sure what the compliance laws are in India in terms of the legal sense of sending and administering these opioids, but if you're able to do that legally, I highly recommend that. Aside from that, NSAIDs, meloxicam, especially because, like I said, the oral constitution of the oral suspension of meloxicam is flavored here, the kind of brand version we get, so it's really easy to get cats to take that. Another thing you can look into is amantadine. We don't have it readily available here at Massey, but there are a lot of private specialty centers that I've been to in Australia and New Zealand that like to use amantadine. So, it's an NMDA agonist, so like similar to ketamine. So very good with working to prevent wind-up pain. So that's another good thing. And then with cats, the huge thing that we always kind of forget with our feline patients is just their behavior and the stereotypical behavior. It's very important to keep these cats comfortable. Making sure that they're eating well. Nutrition is a very, very important part of our patients that we often overlook. Here at Massey, we are calculating on a caloric basis what the average food requirements are for our patients in terms of the metabolic our energy requirements and as well as the resting energy requirements. So we'll calculate that. We actually used to have boarded nutrition clinical nutrition residents who would calculate feed plans for all of our patients. And if we deem that our patients are not getting enough food and we're not able to entice them by giving mirtazapine or something to give them have an appetite, then we will place esophageal feeding tubes to continuously administer what is needed nutrition. Because remember, especially in the with distal limb injuries, cats, dogs, it's going to take a long time. You want to make sure your patient is having adequate nutrition status, or that's going to be kind of a insidious thing that's lurking in the background that's going to further complicate your healing going down the line. And then obviously anxiolysis. If your cat, once they go home, if they're in a multi-cat household, the other cats oftentimes will act up to these patients just because this cat's coming in with all types of different smells from hospital. So giving the cat a kind of nice environment and giving them, even trazodone or gabapentin to keep them a bit sedate is something I find myself doing. Not too often because I don't want to sedate patients without any necessity, but if they are fractious or anxious, then that's another thing. It's not necessarily analgesia, but anxiolysis is a part of good analgesia. So I would recommend that.
Thank you, Surya, for your elaborative information. I would like to thank Dr. Sivasankar also. He is traveling, from, he's coming to Chennai now. So,
Sir is
thanks,
my guru.
Sivasankar.
He's given me
While
many
traveling, you are
opportunities.
Thank you,
contributing
sir.
to us. Thank you very much.
Thank you so
And
much.
I would like to thank Hatvet PHARMA. Dr. Kyagi is my old friend, veterinarian, a student, now become an industrialist. And he is spending money for the educational activity. He is the one I told my views. He came forward, he is helping to create Veterinary Emergency Critical Care Society of India. So this is the society having highest number of students, highest number of PhDs, highest number of practitioners are available and academicians. So we all together, we'll share our knowledge. I would like to, on behalf of the veterinary community, I thank Hatvet PHARMA for providing this platform. And thank you very much. With this, we'll wind up.